Thank you, Chaturanga, for those kind words of introduction. So, good morning, ladies and gentlemen. Thank you, President KSM and the Council for giving me this opportunity. So, today I'm going to speak about gut feeling and overview of functional abdominal pain in children. So, before I start my presentation, let me ask one question. Can our gut feel? Is our gut vulnerable to stresses? So, with that opening question, let me go into my presentation. So, I'll start with a case scenario. This is something you come across in your routine clinical practice. A 7-year-old boy presents to pediatric clinic with intermittent periumbilical abdominal pain for the last 3 months. There are no other associated symptoms. His appetite is good, no altered bowel habits, he is growing along the centiles. The systemic examination is apparently normal. Baseline blood investigations, urine fold report, and the ultrasound scan abdomen is also normal. So now we have a problem, but investigations, examinations, all seems to be normal. So what's next? So it's a dilemma, isn't it? So as pediatricians, we come across this sort of case scenario in routine practice. I'm sure the other doctors, junior doctors, and even the GPs would come across similar presentations in your clinical practice. So what are we going to do next? So that's what I'm going to speak in the next 30 to 40 minutes. So the outline of my presentation is I'm going to speak about chronic abdominal pain and functional abdominal pain disorders, etiopathogenesis of functional abdominal pain disorders, the pathophysiology, I will be touching about the futuristic view of management of functional abdominal pain disorders. Right. Now, why are we speaking about this topic today? Is chronic abdominal pain in children important? If so, why is it important? So, can you hear? Can you hear? Yeah. Speakers and no? Mic not. No problem. Sorry for the interruption. I think we have to go without mic. If you can come forward, I think that will be easy. Please plenty. Shall I start? Are you online classes ahead? Online ahead. That's. Huh? Computer again. Oh. Yeah. So sorry for that interruption. So it can happen in your day-to-day life. So we'll face it and hope you can hear the last row. Yeah. Fine. So chronic abdominal pain in children. Why is it important? Why are we focusing on that, and why are we giving importance? So it can affect a child's well-being. We all love children, and it can affect the children's well-being. So it's a real problem, and it can be bothersome not only to the child but also to the family as well as all the caretakers. And school misses. Now, children with abdominal pain, we routinely come across, they miss their schools. Therefore, it can have a negative impact on their academic performances. And the investigations and treatment can be very costly. It can be expensive not only to the family but also to the government, which is spending a lot on the health sector budget. So, therefore, it's an important problem. And if you look at the prevalence, it's ranging up to 19%. So, based on different studies, that's why there's a big range of 1 to 19%, but it can affect up to 19% of children. So, that means every 1 in 5 child can be affected by functional chronic abdominal pain in children. Now, if you look at the list of causes for chronic abdominal pain, there are a big list which includes GI causes, hepatic causes, renal causes, as well as gynecological and other miscellaneous causes. Now, these are all causes for chronic abdominal pain in children. If you look at this study which was done in Sri Lanka probably 14 years back, where we had been looking for organic causes for chronic abdominal pain in Sri Lanka. So, if you look at this, it's a small study, but see, it's only 10% of children had organic causes for chronic abdominal pain. So, what is the remaining 90%? What is the balance 90% which is giving rise to abdominal pain in children? So, there is a significant group of children who are having abdominal pain, but without any organic causes. So, that is the topic of the talk today. The remaining conditions, or what other condition can lead to chronic abdominal pain in children, is what we are going to speak. That may be functional abdominal pain disorder. So, it's not the functional abdominal pain we are speaking, it's categorized into a functional abdominal pain disorder now, because there are multiple other conditions which come under this group. So, if you look at the nomenclature, this functional abdominal pain disorder name has been in practice for last, we'll say 1 decade or so, but this problem has been investigated for last 70 years or so. So, the first study on abdominal pain in children was done in 1950s. So, it has been investigated for 70 years or so. Initially, it has been called as recurrent abdominal pain. Now, we call it as functional abdominal pain disorders, but already the terminology has been changing, and the current terminology is disorders of gut-brain interaction. So, this comes to my title, gut feeling. So, does the gut feel? Yes. Your abdominal pain or the abdominal pain in children can be related to the gut-brain interaction. So, there is something to do with the brain, there is something to do with the thinking, and there is something to do with the perception. So, although we use the functional abdominal pain disorders nomenclature, now it's going to change to disorders of gut-brain interaction. So, there are 4 conditions under this functional abdominal pain disorders. It is according to the Rome 4 classification: the functional dyspepsia, irritable bowel syndrome, abdominal migraine, and the functional abdominal pain not otherwise specified. So, these 4 groups together create this group of condition which is called as functional abdominal pain disorders. So, if you look at this criteria, so we'll first focus on the irritable bowel syndrome. All these conditions, generally there are 2 important numbers are there. One number is number 2, the other number is number 4. If I tell you detailedly, the number 2 means these symptoms should be there for at least 2 months. That means the abdominal pain should be there at least for 2 months, and it should happen 4 days a month. So, 2 and 4 are 2 important numbers for functional abdominal pain disorders. So all these conditions will have these two things. In addition to that, if you focus on irritable bowel syndrome, so a child if comes with abdominal pain which is associated with defecation, or there is some change in the frequency of stools and the appearance of stools, and there is abdominal pain does not resolve after defecation. So these features are suggestive of irritable bowel syndrome in a child who comes with functional abdominal pain. If you look at functional dyspepsia, if a child comes with abdominal pain with postprandial fullness or early satiation, that is when you eat a little you feel fullness, or if there is epigastric pain or burning sensation which is not associated with defecation, then it is suggestive of functional dyspepsia. So this is what we generally, patients or parents come and say gastritis, or we used to say gastroesophageal reflux, all come under this group. Then the third group of functional abdominal pain disorder is the abdominal migraine. So it's almost similar to the headache, migraine headache what we get, but the migraine is happening in the abdomen. Here the salient features are paroxysmal episode of intense acute periumbilical pain, which is the episodes happen weeks or months in between and interferes with normal activities. Now we all know functional abdominal pain disorders do not interfere with normal activities, but if you take the abdominal migraine, it would interfere with the routine activities like the migraine headache. And also there are other symptoms such as nausea, vomiting, dizziness, anorexia, photophobia. So you can see it's almost similar to the CNS migraine. Then the last group is the functional abdominal pain not otherwise specified. So if you have a child who is having chronic abdominal pain, there are no organic causes, all the features of functional abdominal pain is there, but does not fall into any of the three first categories, then you call it as functional abdominal pain, otherwise not specified. So what is the global prevalence of functional abdominal pain disorders? So again, there are studies has been done only in few countries. So Africa, part of Asia, Australia has been omitted in this study, but the global prevalence says it is 13.5%. That means 1 in every 8 child. So 1 in every 8 child might be affected with functional abdominal pain disorders. So that's a significant number. So this is the global prevalence. What about our country? What about Sri Lanka? So this is again a study which was completed in 2008. Over a few years it was done and completed in 2008. So in the Gampar district, it's around 10 to 16%. In Western Province whole, it's 13%. In Ampara, it's 11%. If you look at the island wide, it's 12.5%. So it's almost similar to the global prevalence, isn't it? If you look at the global prevalence, it was 13.5. In Sri Lanka, it's 12.5. So it's a significant number again. So it's fair enough for us to be worried. So this diagrams, it looks sort of complicated diagram. It shows the etiopathogenesis and pathophysiology of functional abdominal pain disorders. So it's multifactorial. Now there are three main groups of etiological factors. That is sensitizing medical events. That is number 1. Number 2 is the genetic predisposition. And the number 3 is the psychosocial events. So all these group of conditions from infancy might predispose the child to development of functional abdominal pain disorders by creating some impact on the microbiota, gut, brain axis. We will go through about each of these factors later. So these three groups of conditions or the etiological factors will do some changes in your gut, microbiota, brain axis and will lead or will predispose the children. So these are the factors which I have listed now. So visceral hypersensitivity, central sensitization, neuroimmune interactions, early life events, gastrointestinal motility, microbiota, nutrition and psychological factors. So whatever which has been described in the previous picture has been sort of categorized here. So we'll go one by one because it's important to understand these pathophysiological factors for you to manage functional abdominal pain disorders. Without the understanding of this, you won't be able to treat. And these factors can be in fact divided into two groups, central and peripheral. Now, which conditions we will be calling as central? Now, for example, visceral hypersensitivity and central sensitization, it's something to do with the brain. So it's a central factor. Your gastrointestinal motility, microbiota, nutrition, this is something to do with the gut. So it's called as a peripheral factor. So what is visceral hypersensitivity? Now, for example, now if when I am walking, if I hit my elbow in the wall, I might just touch and go. If another person hits with the same impact, but might have a severe pain. So pain is individual, isn't it? Everyone would respond it to pain different ways. Same thing is applicable here as well. Now, you need to understand this pain gate phenomena which is shown here. In the pain gate phenomena, when the gut feels the pain, the signals are being sent to the brain. And there is another signal which is coming down which inhibits the sensation. If your pain sensation which goes up is it being excited, you will feel severe pain. If the inhibition is not properly happening, again you will feel severe pain. So this is what is explained by visceral hypersensitivity and central sensitization. And if you look at the third box down, the amplification of pain sensitivity, in some children, the brain feels the pain too much than the others. That is called the amplification of pain sensitivity. That's why this gut feeling comes into play. If your gut is feeling a sensation, if your brain is taking it in a different way, children will come with abdominal pain. Then the second group of risk factors, the early life events. We'll see what are the early life events which can predispose the babies or the children to the functional abdominal pain. Sorry about this. So there's a problem with this. I'll tell you. Now, if a child has been admitted to the special care baby unit as a neonate, or if the child has been admitted to the neonatal intensive care as a neonate, that can be a risk factor for a baby to develop functional abdominal pain as a child or as an adolescent. And frequent gastric suctions. Now, we all know in neonatal units or in the pediatric units, we tend to suck the NG, or we tend to suck the stomach of the babies for various reasons. That is a risk factor for development of functional abdominal pain in children. And also stressful events very early in the neonate. If the baby is separated from the mother for some reason and admitted to the hospital or been admitted to some center, those children are vulnerable. And children of diabetic mothers, children of pregnancy-induced hypertension mothers, they are at risk of functional abdominal pain disorders. And neonates and infants who undergo surgery in their early life, such as we'll say pyloric stenosis or a surgery for Hirschsprung's disease, necrotizing enterocolitis, any surgeries related to the GI tract, those children are vulnerable to develop abdominal pain later in their childhood. The next pathophysiologic component is the gastrointestinal motility. Now, in children with functional abdominal pain disorders, studies have shown there is delayed gastric emptying, reduced gastric accommodation, delayed colonic transit, and also there is pelvic floor dyssynergia. So these all can lead or contribute to functional abdominal pain. So this is again a study done in Sri Lanka. So if you look at controls versus the other four groups, the functional abdominal pain group, IBS group, functional dyspepsia group, and the abdominal migraine group, all four, the gastric emptying rate is reduced compared to the controls. Same happens with the enteral motility index. That's also reduced. So these children have gastric motor abnormalities. What about microbiota? Now we speak about microbiota brain axis. So what about microbiota? The green box which is on the left of my side, the left here, these are the pathogens which are going to be beneficial to our body. The bifidobacterium, faecalibacterium and the clostridioides. Whereas lactobacilli, enterobacteriaceae and bacteroids are harmful organisms to our body. Now, what happens in children with functional abdominal pain disorders? So, children with functional abdominal pain disorders, these microorganisms are less in their gut, whereas the pathogenic organisms are increased. So, there is a disturbance of the gut microbiota which can lead to risk of abdominal pain disorders. Then also, as we all know, nutrition can play an important role. So, in around 93% of children with functional abdominal pain disorders, there is one food, at least one food, which will worsen their GI symptom. And also, some of these children are more prone to have malabsorption of carbohydrates. Then psychological stresses. So, again, we are thinking about some sort of a psychological event which can give rise to functional abdominal pain. Again, that slide is also not coming. So, psychological stresses such as now punishment in the school, separation from a friend, or some sort of a stressful event as an infant or as a child can lead to functional abdominal pain. Especially irritable bowel syndrome is associated with this sort of psychological events. And what about child abuse? So, if you look at the red columns, so it's maroon columns, children who have undergone physical abuse, emotional abuse or sexual abuse are reporting high number of functional abdominal pain disorders, whereas the controls, the blue group, which have not undergone abuse or which are not children who are not vulnerable to abuse, are slightly less. So that is again another important psychological stress which is predisposing. So we spoke about the etiopathogenesis, the pathophysiological factors. Now let us go to diagnosis. So as always, you will have to have history examination, and here we use something called the Rome-4 criteria or Rome-4 questionnaire, baseline investigations and other special investigations. So detailed patient history and thorough examination is important. So in the history, you focus about the characteristics of pain, what is the type, location, severity, and what are the factors which increases the pain and what are the factors which reduces the pain. And also you need to focus and you need to clearly ask from the parents, is there any disturbance or pain occurring during sleep? And there are certain hints or the hallmark features of functional abdominal pain disorders, that is stereotypical symptoms. Pain which is usually periumbilical, and the children would say continuous pain, 24 hours a day they have pain. And pain does not wake up them from the sleep, but if there is a stressful event next day, if there is an examination or if there is some sort of event in the school, they might have disturbance of sleep on the previous night. And also there are associated other somatic symptoms such as headache, dizziness, arthralgia, myalgia with the abdominal pain. That is again another hint for you to think or suspect functional abdominal pain disorders. And further into the history, always ask about the psychosocial status of the parents, because that's one of the common factors which is associated with functional abdominal pain. And always look for red flag signs, because you might be dealing with a child who is having another problem. So always try to exclude that. And look for any symptom which is coming with a stressful event. If something stressful happening and the child is developing a particular symptom, that is a clue here again. And do not forget about this. When you examine the child, if you can distract the child and if that distraction relieves the pain, that is another clue or another suggestive feature of functional abdominal pain. Then I spoke about Rome-4 criteria. So this is a criteria which is specifically made for functional abdominal pain disorders. It's not only in children but also in adults also it's been used. So that will help you to come to a diagnosis. So it's a list of questions which parents can answer or the children can answer. And importantly, the bottom line of Rome-4 criteria is to, the wording what they said is, you need to diagnose functional abdominal pain disorder. After appropriate evaluation, the abdominal pain cannot be fully explained by another medical condition. So, if you exclude the other conditions only or clinically if you exclude, you have to suspect. And as clinicians, as treating doctors, it's our responsibility to decide what is that appropriate evaluation, whether we need to just base on the history or whether we need to go for any investigation. So that would depend on the clinical picture and the clinician has to decide. So what about investigations? What is the place for the investigations? So there is no golden tool or golden diagnostic tool to diagnose functional abdominal pain. So if there are any lab tests you need to do, it has to be a targeted and focused one. You can't haphazardly do all the investigations. Sometimes baseline blood investigations might be useful, such as a full blood count where you would be looking for HB or inflammatory markers such as CRP. That might be useful. The evidence show that certain tests such as serological testing for celiac disease and fecal calprotectin to look for inflammatory bowel disease, that is a very cost effective test, because some of these children will have similar symptoms like celiac disease or inflammatory bowel disease. And it's a common belief that Helicobacter pylori is related to functional abdominal pain disorders. But in fact, evidence show that it is not associated, as well as eradication of H. pylori does not improve the symptoms. So I'm sure H. pylori has been it's a common problem in adults, but it does not have any association with functional abdominal pain. What about the role of endoscopy in functional abdominal pain? Now, just to diagnose functional abdominal pain, you don't need to do a endoscopy. But common argument among people and as well as doctors is to, if you do endoscopy, negative endoscopy will sort of reassure the parents. But a study has been done on that, and it has proven that despite negative endoscopy, it creates anxiety whether something is being missed in the endoscopy. So despite you doing an invasive procedure, parents still think there might be something would have been missed by the endoscopy. So endoscopy per se does not relieve the anxiety or the symptoms. Yeah, so endoscopy is not routinely indicated unless if you have a red flag sign or if you have a clinical suspicion of some other disease. Otherwise, endoscopy is not recommended. So this is a diagnostic pathway. So it's small in size, the letters are small in size, but I'm sure you can see. So if a child comes with abdominal pain with change in bowel habits, you will have to suspect irritable bowel syndrome. If there is postprandial symptoms with the abdominal pain, you have to suspect functional dyspepsia. If there are sort of paroxysmal events which also has some components of headache and other symptoms, you will have to think of abdominal migraine. And if you have all features of functional abdominal pain but does not fall into any of these category, you will have to think of the non-specified or the unspecified group. Right. Now let's move on to management. Now the key here is pharmacological events only does not prevent functional abdominal pain, or it's not useful or it's not successful. There are certain behavioral treatments which are very, very effective, but we cannot apply in our setup because we don't have the experts. You need specific dietitians, nutritionists, psychologists who are trained on this. So we don't have that facility. And when it comes to management, now we always look at evidence-based medicine. We follow randomized control trials and those conclusions we practice. But most of these drug randomized control trials have been done on adults. And even the studies which have been done in children are only focusing on irritable bowel syndrome. The other three components are not being covered. So this is a challenge. So management is a real challenge or a dilemma for us. And compared to adults with functional abdominal pain disorders, children do not respond very well. So what are the options we have? So we can categorize into 4 groups when it comes to management. So it's the 4 types of approaches you can do. One is important thing is the communication, then the dietary modifications, psychological interventions, and the pharmacotherapy. So Now, communication is very, very important when it comes to functional disorders. So, there's no exception in functional abdominal pain disorders as well. You need to build a very good relationship with the child if the child is adolescent child, or if it's a small child, you need to have a good relationship with the parents. And it's important to educate the parents and the children in regarding the underlying problem. You explain the diagnosis, what is the reason, what are the management options, and you need to understand the unique biopsychosocial model. What do I mean by that? Now, if you look at the etiopathogenesis, each child would have had one particular reason for this condition to develop, or there would have been multiple conditions. So, treatment, you can't put a blanket sort of umbrella treatment to everyone. It has to be specified for individual, and depending on whether it's a central cause, whether it's a peripheral cause, whether it's psychosocial related, whether it's gastric motility related or microbiota related. Likewise, you need to identify and you have to go for a specific unique treatment for each child. What about the dietary modifications? Now, here I am using a color code for you all to understand. I will tell you what. Now, these are the 4 dietary modifications.
Could I ask the online listener to keep their mics off, microphones? Sorry for this.
So, dietary modifications, we have 4 groups. If you look at the first 3, that's in green in color. What does it mean is this has evidence-based support to use these medications. Whereas the yellow one, it says there are mixed findings. So there you can't. It's not a recommendation basically. So what is this low FODMAP diet? Any idea? Anyone? FODMAP? Anyone? So FODMAP is a sort of abbreviation. O is fermented oligosaccharides. D is for disaccharides. M is for monosaccharides, and polynol. So there are certain foods which has FODMAP. These foods can be associated with development of functional abdominal pain disorders or the symptoms. Therefore, in the dietary modification, low FODMAP diet is being recommended. I will tell you what are the foods. So we have to reduce the FODMAP containing food. Then prebiotics and probiotics, because this is something to relate with the gut microbiota. Therefore, prebiotics and probiotics has a place. And in some children, it has been shown that there is enzyme deficiencies, such as for some particular oligosaccharides. So, particular enzyme supplement can be helpful, and fiber supplementation. So, the fiber has been used in children with irritable bowel syndrome who has constipation. Okay, and gluten-free diet. So, why gluten-free diet is being coded in yellow is because only in particular group of children with functional abdominal pain disorders, gluten-free diet is working. Whereas in other children it doesn't work, so we cannot use it in all children. So these are the foods which contain FODMAP. So if you look, asparagus among vegetables, asparagus, cauliflower is there. Among fruits, apple, watermelon is there. Dairy products are there. Then wheat containing, barley containing, and honey, coffee, all those things are there. So, and also cashew and pistachio. Now, these foods have high FODMAP. If your patient, by reducing these foods, if there is an improvement of symptoms, then you can happily reduce FODMAP containing food and you can go for the other options. What is the evidence for fiber supplementation? So, if you look at several studies here, all the studies are showing favorable sort of outcome with the fiber supplementation. So if you look at all these 3 studies, so they are favoring towards the fiber in comparison to the placebo. So it's a Cochrane database study from 2017. What about the probiotics? Again, there are several probiotics, several microorganisms has been tried. Among them, Lactobacillus reuteri has been effective, where 5 trials have been done, 3 beneficial, 2 inconclusive. So we pediatricians, we all know lactobacillus reuteri is being also used in infantile colic, which is one and only effective treatment, I would say, when it comes to pharmaceutical options. So that is again effective in children with functional abdominal pain disorders. So what are the psychological interventions? So you have hypnotherapy, neurostimulation, which both show some evidence of promise, whereas cognitive behavioral therapy has some equivocal findings, not effective in all children, but treatment options like yoga therapy or alternative medicine does not have any randomized trials being done. Therefore, the study group does not recommend these two options as effective psychological interventions for functional abdominal pain. Finally, pharmacological therapy. Again, there are 5 groups of drugs: antispasmodics, antibiotics, antidepressants, analgesics, and laxatives. So, if you look the evidence, among antispasmodics, peppermint oil, trimbutene, and mebaverine have been effective. These drugs, peppermint oil comes in capsule form. Mebaverine is commonly used in functional abdominal pain disorders in children. It's now not all centers have. Later Ridgeway Hospital has it, but outside you can purchase. Among the antibiotics, rifaximin is a non-absorbable antibiotic, but we do not have enough evidence for it to be used in children. So adults, it's very promising, but in children, there is sort of 50-50 evidence. That's why I have coded it in yellow. Amitriptyline is one of the effective antidepressants, especially children above 5 years. You can use, especially for irritable bowel syndrome. Then gabapentin is a useful analgesic agent. And finally, there are few laxatives. Again, among this, lubiprostone is being used in some of the pediatric centers. So, except for rifaximin, the other all have enough evidence and safe enough to be used in children. So, this therapeutic algorithm for children with irritable bowel syndrome. So, as I mentioned earlier, there are 2 categories of irritable bowel syndrome: irritable bowel syndrome with constipation, irritable bowel syndrome with diarrhea. So, if children with irritable bowel syndrome having constipation, you can use laxatives, probiotics, and also cognitive behavioral therapy. And sometimes prokinetics are also effective because there is constipation, which will increase the gastric motility. If there is IBS with D, that is with diarrhea, of course, you can try the low FODMAP diet, you can try probiotics, you can try antibiotics, and also sometimes antispasmodics. Loperamide also has been used. What are the treatment options for functional dyspepsia? As I mentioned earlier, functional dyspepsia has 2 groups: the postprandial group and the epigastric distress group. So the drugs which are useful in postprandial is cyproheptadine, and this is a drug which is used for increasing appetite in children. So if there are no other other structural problems, you use it for increasing appetite, but that is being used for postprandial syndrome. Peppermint oil has been used. Then 5-HT receptor blockers, antiemetics, and then the psychotherapy. For epigastric distress syndrome, this is what we all commonly treat as gastritis. So antacids, as we all use, antacids can be used. Cyproheptadine again you have the neuromodulation or the CBT. And when it comes to diet in functional dyspepsia, the recommendation is to use small frequent feeds which with low fat diet. So that is one of the common things we all can practice. So if you suspect a child has functional dyspepsia and functional abdominal pain, you advise to give small frequent feeds which is having low fat. So what are the management options for abdominal migraine? Now it's almost similar to the migraine headache what we have. So you have to prevent the exposure or the known triggers. So whatever the triggering factor you identify, some children would develop it after exhausted after a sports activity or exposure to sunlight or starvation. So you have to prevent those exposures. And for prophylaxis, again, cyproheptadine is useful. Propranolol, like in a migraine headache, you can use amitriptyline and pizotifene. For the acute management, you can give pain relief, antiemetic agents, as well as triptans can be used. So this up to now what I have been speaking is what is the current practice in regard to all these functional abdominal pain disorders. But now what you see in the West is a sort of a paradigm shift, and there is some new sort of concepts appearing when it comes to management of functional abdominal pain disorders. So now rather than symptomatically treating, they are targeting the underlying etiopathogenic factor. So current approach or the novel approach in the management is to focus what is the mechanism. Now, when I spoke about the etiopathogenesis earlier, I told you about the central causes and peripheral causes. If it is something to do with the brain or if it is something to do with the psychological stress, that is known as central mechanism. But if it is something to do with the gut or the microorganisms infection, it is known to call as peripheral mechanisms. Now they are targeting that. So if it is central mechanism predominant, that means if this child has undergone or has been vulnerable for abuse, stress, anxiety, depression in the early life, and if this child is developing functional abdominal pain, we need to target the central mechanism where you will be focusing on counseling, CBT, hypnotherapy, antidepressants, etc., etc. If you are suspecting a peripheral mechanism as the cause, for example, post-infectious or gut dysmotility, abnormal microbiota, dietary triggers, immune mediated, so something to do only with the gut, then your focus is motility drugs, antispasmodics, probiotics, antihistamines, and dietary modifications. Now, some of these children can have both, can have central mechanism as well as peripheral mechanism, which would give rise to these symptoms. In those children, you will have to combine both. So, this is the novel concept now being practiced, and this is going to be the most effective and successful way of managing functional abdominal pain disorders in the future. Right. So, with that, let me summarize my presentation. So, functional abdominal pain disorders are common in children, not only locally, but globally as well. The important problem here is disruption of the microbiota gut-brain axis. And as I mentioned earlier, no investigation will establish diagnosis. The management is multifaceted approach, but is unique for each individual. And understanding the etiopathogenesis is important for the management. Rather than umbrella management, you need to individualize your management. So these are my references. And also I would like to thank Professor Shaman Rajit, who provided me with the research data. Thank you.
Thank you, Mr. Pradeep. So if you have any questions, you can directly ask us. Otherwise, we have the mic today with the speaker. Now, so from lot of parents in our country do home treatment, home remedies for abdominal pain. So sometimes they give rice water, shampoo for the foot. So I don't think any of those things is proven, but I think still a lot of people practice that. Do you have to say anything about that?
So the question by Professor Samananayakara was, there are certain home remedies being practiced by our mothers. What's your opinion on that? Right? So now, generally when it comes to management, we speak about randomized studies or evidence-based. So there are no evidence on this. But now peppermint oil is something initially being practiced like this. It has been practiced as a home remedy and later it has been tried and randomized and now been effective. Now this dietary modifications, certain things we in fact practice. We all practice at homes. We do certain things. Until as far as it's not harmful to the child and there are no side effects to whatever we give, then those can be practiced. But as a clinician or as a doctor, I don't have enough evidence to say anything on that. But my bottom line is if those things are not harmful. Now, there are certain things when you give orally. Now, we have children who have been treated at home for different problems where they come with, when there's a herbal treatment being given, they come with liver failure or hemolysis. So those are not advised, but certain things which are commonly used at home. Now even drinking kottamalli is I don't know about evidence, but we all practice and it's helpful. So likewise, if it is not harmful and it's safe, then of course you can practice.
Pradeep, another question. So for example, then when they come with abdominal pain, sometimes we do investigations. So like ultrasound scans. So what is the line of investigation you think the moment they came in, depending on clinical grounds, sometimes we do X-rays. So how do you recommend to proceed with the investigations? Because sometimes sometimes we feel we are overdoing certain things and exposing to X-rays maybe considerable risk as well.
Yeah. So the question from Chaturanga is now when a patient comes with abdominal pain, like what is our limit for investigations? So what investigation we can do, and where is the line? So in fact, it all depends on the history, examination, and are you worried about something? Now, commonly functional abdominal pain disorders, if you see children, their history is very unique. They will have all the features, so at least a lot of features of functional abdominal pain. And in the examination, you would not find anything. Now, but sometimes your clinical examination, you might miss certain things. So doing an ultrasound scan abdomen is not harmful because certain things you don't get with your palpation, you might not find, but you might find some abnormalities in the scan. And if it is related to this particular condition, yes. Sometimes if you see a child with abdominal pain and if you have a hepatomegaly, splenomegaly, or some other findings, then of course you will have to go for investigation. So depending on the clinical findings, so again, the answer is you can't give an umbrella answer for that. It depends on the individual patient and it depends on the individual concern of the clinician. So it's a clinical decision to be made at that point. But no investigation would be sort of definitive diagnostic to diagnose functional abdominal pain or to exclude abdominal diagnose or other conditions.
Congratulations for the wonderful lecture. Some parents go on giving anti-worm treatment. How frequently is recommended and that is the
Yeah. So now anti-worm treatment. Now in Sri Lanka, so I'll just go into story now. In Sri Lanka, earlier allergic conditions were not very common. Nowadays, we see lots of allergies, whereas in Western world, allergies are common. So one of the common reasons being told by experts now is it's probably due to the anti-worm treatment. We are over-treating children. We are it's sort of completely clearing everything which is probably predisposing children. So our current recommendation is to treat children every 6 months with anti-worm treatment. But there are children who have troublesome worm infestation, who might come in 2 to 3 months with worm infestation. Then of course you will have to treat, but depending on the socio-economical factors, children who are at risk of worm infestations based on their environmental factors, you might have to treat early. But generally, we all, I'm sure the other senior pediatricians would like to add, we generally treat it once in 6 months in children.
Pradeep, there's another one. We have seen a lot of referrals coming with, having children. I generally don't see that 10 to 12 years, but I've seen treated with PPIs, etc. So, what is your opinion on that?
So PPI for the abdominal pain.
Yeah.
Yeah. So PPI is a drug of choice when it comes to functional dyspepsia. So you can use antacids and you can use PPIs. And also again, the Espagan and Naspagan has recommended PPI for gastroesophageal reflux. So it's a safe drug. So in not only PPI, the H2 receptor blockers, ranitidine has been recommended as a drug. So those two agents are sort of effective. But now antacids, now aluminum hydroxide containing antacids cannot be used in children safely. You can't go for a long period because it has toxicity as well as it can lead to constipation. Whereas these PPI and H2 receptors can be used, but it's not again just for any abdominal pain. If you have specific features for functional dyspepsia or gastroesophageal reflux, then it's recommended. Now, even for children of 3 months who come with severe troublesome reflux, we can use omeprazole, we can use ranitidine. So the 2020 update of Esfagan has said in small children also you can use ranitidine and omeprazole without any worries, but not to use the antacids, especially the aluminum hydroxide containing ones.
Thank you very much for the information. So, common one might seem it's very easy. I want to ask, before management of abdominal bleeding, you put the on the last industry. My experience, this is the last, but compared to the proper combination, I mean, I did it twice as well as the
Yeah, the question by Dr. Jayanta is now in the abdominal migraine management, we have a few drugs. Propranolol was there as well as pisotifen. So I do agree, madam. Pisotifen is very useful. Nowadays, propranolol is going out of sort of fashion. It's not being commonly used. So topiramate, pisotifen are coming on top in the list. So I agree. Although I have put it in that order, it doesn't mean propranolol is superior to pisotifen. Pisotifen is very well accepted by children as well as it's being commonly used by all clinicians.
I think,
Thank you.